But it's also important to know for some of our full arch cases too. And this is a patient who needs a full maxillary case replaced. She doesn't like her denture. She had a beautiful restoration done by Dr. Panos Papaspyridakos when he was a resident at Columbia University. And she just wanted to duplicate what she had in the denture as part of her a fixed restoration. So we went ahead and used some of the more advanced techniques. You can see that there's a significant resorption in the maxilla. So our challenge is going to be to make the most use of every square or cubic millimeter of available bone. There's nothing to spare on her. So we go through and do a full digital workflow. Here you see just she has a cone beam, and this is an optical scan using some markers on her denture and occlusion. And we can use that information to do a plan to optimize use of available bone. And then we're now using some of these stacked components, which are prefabricated frames and surgical guides that allow us to do the bone reduction, implant osteotomies, and a prefabricated provisional all at once. And the way this particular system works is this frame is pinned, actually it's screwed into the maxilla, and then there are pieces that are pinned into it. For instance, that's the drill guide right here, and it results in implants that are pretty much exactly where we wanted to place them. Yes, there are some dehiscences here, but we're going to use Osstell in order to figure out what is the primary stability. How solid are these implants? Because we now have the advantage of some cross-arch stabilization and really some precision occlusal management in order to make sure that this case is going to be successful. So before attaching abutments, you must make sure that each individual implant has its stability recorded. So here you see the abutment connection. This is the provisional before it is luted in place, just from the framework. And just as another example, we use robotics as well sometimes. This is an example of guided osteotomy, and if you look in the window right here, you'll see that descend in a second. And essentially, it precisely positions where the implant is going, but we also lose all sorts of tactile sensation. So it's very difficult to know what the primary stability is unless you test with something objective like an Osstell. These implants were placed robotically. These are the first implants that we know of placed in the world robotically, and they were all done without looking in the patient's mouth. Is this such a hard case? No, but it just sort of proves the technique.